But if people are trying all these over-the-counters and they're not having the result they want, and they tell you, you know, I really kind of cleaned up my act and I don't use my iPhone in bed or my other kind of phone in bed, let's not demonize iPhones per se, and I don't take naps and I don't have coffee and I don't drink alcohol and I've tried these over-the-counter meds and they're not working. When do you move from there to more prescription medications in the elderly?
Obviously, I mean,
Yeah.
go ahead.
Yeah, you know, one of the things that we've left out of this equation here is the distress of the patient. And, you know, a lot of the things that we do, you know, sleep hygiene is wonderful, but you have to measure it against the distress of the patient at that moment in time as to what you're going to do. And I think that that temporary, some things take longer to do, and that all has to go into the equation. And so I think that's the first step. And we've talked about all these various options, and there's a time factor involved. There's the acceptance of the patient. You know, part of these herbals is also a little placebo effect built into it, and that you can't discount, which is probably good. And we have to keep all of that in mind. When you've exhausted and now you're confronted with a situation where in the judgment of the clinician, you need to sort of do something else to help this patient out, because they're not going to believe you that just make all these changes in your life, then that's when you would start considering other medications.
Okay. I've always been kind of a therapeutic nihilist myself. If we don't have to use medication at all, let's not. It sounds to me the key core of what you were saying is the distress of the patient.
Well, and the acceptance of the patient. I have patients who come to see me and they say, I'm just want a pill, I'm not going to listen to anything else. I have other patients come to me, like the therapeutic nihilist here, who say, no pills, no medications, never, nothing.
There's a middle ground, probably.
And there are people in the middle, people who do both. People may start off with some medication and do the other things as well. And to me, it's a matter of judging it and dealing with the patient.
You know, the other thing I hear from all of you is that this can be terribly distressing, and that patients who have, almost by definition, if they have insomnia, they're unhappy, and it's affecting them in some deleterious way. So the question is, what is the urgency of treating this? I mean, it takes time. If you're going to do sleep hygiene, clean up your act, stay in bed, try this. Now you're talking days and weeks, maybe try over the counter. Now it's weeks and months, and still the patient's not doing well. Is there a point where you say, let's do something else? This is an urgent situation. Does it ever get there?
Urgent?
Urgent.
Well, again, that's dictated by the patient. I don't think it necessarily has to do anything with the time. You know, there are some people who may be having insomnia for a few weeks and they're desperate. And other people, and it's common, people come in and they say, well, you know, it always took me 2 hours to fall asleep and so to get by, but now it's starting to get a little worse, and it's been going on for years. So time is not the issue here. I think, it's the matter of dealing with the patient at hand.
Okay.
That's what dictates
Can
it.
I also add one thing, Sandy? That don't you think also it's a matter of also how impaired the patient is during the day? In other words, when the insomnia has gotten to the point where the patient's not functioning well or is functioning less well, I think, and with behavioral therapy, I think you need to do something to help them function, get back quickly. One of the advantages of pharmacologic therapy is that it works rapidly, whereas cognitive behavioral therapy takes a while to work.
That's what I was
Become to
saying.
effect.
It takes a
So
while to
if
kick
you
in.
need rapid improvement, patient's symptoms are significant enough. I had a patient the other day. He had insomnia for a year and a half. Horrible, debilitating sleep. The man could not work. He needed to get back to work right away. He was going to lose his job. We needed to do something very rapidly to get him there. CBT would have taken weeks, maybe months to work. So I think it's a matter also of how impaired the patient is, how quickly you'd like to expedite therapy. Quite frankly, one of the other issues is availability. In some parts of the country, there are no cognitive behavioral therapists available. So pharmacology is the only going thing. So those practical issues are also problematic.
And there's one other thing that I think that there's a socioeconomic factor here. If hospital I deal with is a safety net hospital, so we see large numbers of people who come to us who are illiterate, where this kind of cognitive behavioral therapy is a very foreign concept to them, and assuming that you can get somebody who can do it in their native language, and so, you know, you're sort of it's nice to go through these things and to have these ideals of how to manage patients, but you have to be practical.
All right. You know, before we launch into a discussion of some of the prescription drugs, I caught something that you said earlier, which is you got to watch it in older patients. That what may be safe in a 20-year-old has some consequences in older folks that we might not like. What for example?
Well, I've had, as we think about, we've talked about falls, but I'll put it, for instance, with the anticholinergics such as diphenhydramine, where an older gentleman has an underlying prostate disorder, enlarged prostate, and that anticholinergic...
Need I just interject when I
Yeah.
hear this? Ouch.
Yeah,
Here it
right?
comes, right?
Yeah, the tipping point for urinary retention that led to urosepsis. And really the tipping point was the use of the diphenhydramine at higher doses for sleep. So really looking at that interaction between the coexisting medical conditions and how those medications might be the tipping point. And so for them to have an exacerbation of that problem. So I think the threshold and our ability to readjust, especially if we have a fall, and I think these medications are not without the implications on falls. And it might be because of the sleepiness, but also because of the blurred vision or other, making them more confused and they're falling more. So I think it's really just being very cognizant of that risk and benefit exchange.
I'll bet we've all gotten a phone call. I have gotten 2 or 3 from a family member saying, my husband, my dad had a cold and now he can't pee, and he's going to the hospital because he's in agony.
Right.
That's
Yeah.
what you're talking about.
Exactly.
And that's not going to happen to a 20-year-old.
Yeah, absolutely. Yep.
And so it's important to recognize
And
that.
people just do not recognize the safety implications of over-the-counters.